Hello, welcome to this Fujifilm Sonasight webinar. My name is Alan Chiem. I'm based at Olive View-UCLA, and today we'll be talking about the use of bedside ultrasound for the management of septic patients. This talk really won't go into the intricacies of fluid responsiveness as well as sepsis syndrome. There are many other talks that will point you toward that. So for instance, anything to do with tissue oxygen delivery or glycocalyx or anything else, those topics are not going to be covered in this talk. What you'll find is that this talk is meant to be practical so that you can use some tidbits on your next shift. I'm going to steer away from the research, although a great body exists on the topic of fluid responsiveness, passive leg raise, and ultrasound. By the end of the talk, hopefully you'll be able to understand how the new Sepsis Bundle, as well as the Sepsis 3 definition applies to your septic patients. Learn how to use ultrasound. We'll go through a simplified and advanced method on assessing for fluid responsiveness. And we'll also go over the passive leg raise. So what is this new CMS Sepsis Bundle? It is a series of measures involving the care of sepsis patients that was developed by a panel of experts and which CMS endorsed and requires as of October 1st, 2015. It's actually part of the CMS Hospital Inpatient Quality Reporting Program, and many institutions have this bundle built into their order sets, but if your institution does not, auditors and coders will still monitor your charting to see if these measures are met. It retains this traditional sepsis framework of the Systemic Inflammatory Response Syndrome, or SIRS, sepsis, severe sepsis, and septic shock. However, the bundle starts when there is evidence of end organ dysfunction, so you don't have to apply the bundle for every septic patient, only those with severe sepsis or septic shock. A key point is that the auditors and coders will be looking at not just your chart, but nursing charts as well as lab results. So it is crucial that your team is all on the same page in terms of documentation. So how does CMS define end organ damage or dysfunction? If patients are hypotensive with a systolic blood pressure less than 90, a relative drop in their normal systolic of greater than 40, or a MAP of less than 65, if there's evidence of acute kidney injury or azotemia, if there's hepatic dysfunction or hemolysis with a T-billy greater than 2, or if there's hematologic or coagulation dysfunction with platelets under 100,000, an iron greater than 1.5, or an activated PTT greater than 60 seconds. If the lactate is also greater than 2.0, then they meet severe sepsis criteria. Many of you may be wondering what to do with patients that have these abnormalities at baseline. We will cover that later in the talk. So let's say you have someone with evidence of end organ dysfunction from sepsis. So what do? First thing you need to do within 3 hours is to measure the lactate, to obtain blood cultures, to give broad spectrum antibiotics, and if they're hypotensive or the lactate is greater than 4, suggesting cryptogenic shock, they needed a 30 cc's per kilogram crystalloid bolus. For the average 70 kilogram patient, we're talking about 2 to 3 liters. Now, if their hypotension is refractory to the fluid bolus, this triggers the septic shock clock. Now you have 6 hours from the time that starts to give fluids or to start inotropic or vasopressor medication. Now, this depends on a reassessment of the patient's volume status or tissue perfusion, and this is where we will talk about ultrasound. But first, if you just want to do a focused physical exam including assessment of tissue perfusion, you'll meet the bundle guidelines. I find that the capillary refill and skin turgor tests are usually inadequate and insensitive, except for those who are severely volume depleted.
Ouch, bro, that kind of hurt.
And of course, some patients may object. So as an alternative to the physical exam, according to the bundle, you can rely on 2 of the following assessments: central venous pressure assessment, central venous oxygen levels, a bedside cardiovascular ultrasound, or a passive leg raise or fluid challenge. We won't cover the evidence for or rather against CVP or CVO2 measurement in this talk. The major limitations are that they require invasive monitoring, and they employ static measurements which are really not predictive of fluid responsiveness and which the field is really moving away from. Why are static measurements so poorly predictive of fluid responsiveness? Well, first, there sometimes is confusion between the related concepts of volume status and fluid responsiveness, but they are not the same. The idea of volume status assumes that whatever is filling the LV or preload will translate to what is ejected out of the LV, and that there is a certain volume or pressure that corresponds to whether patients need or don't need fluid. Prior to the spread of bedside echocardiography, we use invasive measures of pulmonary capillary wedge pressure or the central venous pressure, which are proxies of LV preload. However, over the past decade, study after study have shown that the concept of volume status and preload are inadequate in terms of fluid resuscitation for the septic patient. There are many different reasons for this. One is that it doesn't take into account the systolic function or the vascular resistance. We couldn't really assess systolic function prior to the development of portable ultrasound imaging. Another major reason is that preload itself changes over time. As we'll discuss later, preload is affected by intrathoracic pressure as well as the ability of the LV to stretch with more volume or LV compliance, as well as afterload. For example, two patients may both have an LV and diastolic pressure of 10, and if you give both a 30 cc per kg fluid bolus, one may be able to take that fluid and inject it into the systolic circulation without an appreciable rise in the pressure, while the other patient may not be able to move that fluid and his LV EDP rises, leading to a rise in his left atrial pressure and subsequent development of pulmonary edema. We just don't know how patients will respond until we are able to test it with a trial and measure the response. And as we'll describe later, bedside ultrasound allows the clinician now to assess this trial both at the LV as well as in the major arteries. So if we're moving away from static measurements, we need to actually focus more on the trends and actual dynamic measurements. Now, what do I mean by this? Well, you have your baseline value that you measure. You deliver a trial, such as a small 100 milliliter bolus or passive leg raise, or even a tidal volume, and then you repeat the measurement. And it is this change or delta measurement that is key to predicting fluid responsiveness. So what is fluid responsiveness? Quite simply, it's the increase in cardiac output or stroke volume by more than 10 to 15% with the trial. So for instance, someone with normal LV systolic function, as highlighted by this blue curve, will have a greater than 10 to 15% stroke volume increase if their preload is increased anywhere from A to C. From C to D, they will tolerate fluid without any significant adverse effects, but their stroke volume will not increase significantly. From D onwards, fluid will begin to accumulate in their tissue, leading to tissue hypoxia, as well as pulmonary edema. Now take someone with reduced left ventricular function, is in the purple curve. This is significantly flatter so that their fluid responsiveness window is much reduced. Now it's only from A to B where they will be fluid responsive, B to C where they are fluid tolerant, and C onward where they will suffer adverse effects from fluid administration. The problem is we don't know which curve patients are on, nor their position on the curve unless you perform a trial and then measure the change or delta. And if this delta value exceeds 10 to 15%, then they are fluid responsive. If it does not, then they are not fluid responsive.
So, I get the Frank Starling curve, but I don't really get this Doppler stuff. Is there a simple ED ultrasound protocol I can use for sepsis?
That's a great question, George. So just remember that you need a trial method and the measurement on ultrasound. There is a simplified approach on ultrasound, and it starts with actually looking just for pulmonary edema, looking at the systolic function, and seeing what the IVC respiratory variability is. So the first question prior to a trial is whether there's evidence of pulmonary edema, and ultrasound can reveal subclinical pulmonary edema, i.e. the presence of extravascular lung water prior to symptoms or physical exam findings. To examine this, use a phase array or curvilinear probe and look in the gravity-dependent areas of the axilla, as shown here. And what you'll see are these. So on the left, you have these A lines, which are reverberation artifacts from the pleural interface, from the skin to the pleural interface right here. And these are completely normal. On the right image, you have these right here. These are these vertical lines extending from the pleura all the way down to the deep fields. And these are called B lines. So if you see more than 3 B lines per zone, and that is actually indicative of something called alveolar interstitial syndrome, of which the most common cause of this syndrome is pulmonary edema. So if you see evidence of this, then don't give fluids and just start inotropic or vasopressive support if they're hypotensive. Now, if you don't see pulmonary edema, this is where we need to know which ventricular function curve the patient has. And to do this, we have to look at the systolic function. How do you do this? Well, you want to obtain a peristernal long axis view of the heart using the phase array probe on cardiac exam setting. Depending on your convention, the probe indicator should either point towards the left elbow or the right shoulder. What you'll see on ultrasound is this. You'll see the long axis of the heart right in front of you, where this is the left atrium, this is the anterior mitral valve leaflet, the left ventricle, aortic outflow tract, right ventricle, and this bright white line surrounding the heart is the pericardium, and this is the descending aorta right here. If you see this is a tachycardic hyperdynamic heart where basically the left ventricle is nearly empty at most of the cardiac cycle and definitely at the end of systole. And if you see this in your patient, then you can definitely give lots of fluid because they're at the very steep part of the starting curve. Now if you see this is normal systolic function where the anterior mitral valve leaflet hits the septum. You have thickening and thinning of both the septal wall and the posterior wall of the LV. And then the chamber size changes appreciably between the cardiac cycles. So if you see this, they are on a normal ventricular function curve. Now, if you see this, note that the anterior mitral valve leaflet is nowhere close to the septum. Typically, it should be less than 7 millimeters. And then this chamber actually doesn't change in size at all. And you can see that there's very little contraction of both the septal and the posterior wall below. So these patients have very markedly reduced ventricular function. So once you know the systolic function curve, in order to help us identify whether they will be fluid responsive, we next will take a look at the inferior vena cava. Specifically, we're looking at the IVC diameter change associated with respiration. In a spontaneously breathing patient, the diaphragm descends during inspiration, leading to a negative intrathoracic pressure, whereas the ascent of the diaphragm during expiration causes a positive intrathoracic pressure. It is this change in intrathoracic pressure that is the trial because it affects venous return. When venous return is decreased during expiration, the IVC becomes more plump. When it is increased during inspiration, the IVC begins to collapse. Our measurement is, in fact, looking at the diameter change of the IVC. So in spontaneously breathing patients, we look at IVC collapsibility, which is a difference between the maximal and minimal diameter, divided by the maximal diameter. We don't need to necessarily perform specific measurements. You can usually eyeball a 50% change, and if that is the case, you can give fluids. If they are mechanically ventilated, the mechanics are essentially reversed. Now the tidal volume causes a positive intrathoracic pressure, whereas expiration is associated with negative intrathoracic pressure. For this reason, we are looking at how much the IVC distends with the tidal volume, or the distensibility index. This is the difference between the maximal and minimal diameter divided by the minimal diameter. This you actually have to measure because the cutoff is 18% or more where you can give fluids. So how do we image the IVC on ultrasound? So this is what I like to do. I like to find the short axis of the IVC, as seen here, where you have a bunny sign where the IVC is the head of the bunny and the hepatic veins dumping into the IVC are the ears. And then I like to rotate the indicator 90 degrees so that I get a long axis view of the IVC. So starting from a subxiphoid view, what you want to do is just tilt the probe a little bit more inferiorly until you see that bunny sign right there, and then rotate the probe 90 degrees clockwise so that it's pointed towards the head and you get your IVC in long axis. It's important to do this because you don't want to misidentify the aorta as the IVC, and by doing this you minimize that risk. This is an IVC that has greater than 50% respiratory variability, where it's actually collapsed during inspiration. So in these patients, you can definitely give fluids. Now, if you have an IVC like this, where you basically have very little respiratory variability diameter change, these patients are not going to be patients where you want to give fluids. There's often mention of an IVC maximal diameter cutoff of about 2.1 centimeters or more. I find that this is not as reliable just because if you can see right here that this is actually almost the same diameter as this right here, in that they're greater than 1 centimeters, they're close to 2 centimeters both. But you can see that this has little respiratory variability, whereas this has greater than 50%. So I mentioned that for the distensibility index, you need to perform an actual measurement. To do this, hit the MO button, and what you'll see is this line drop. Place this line about 2 centimeters caudal to the hepatic vein inlet, which is right here, and you'll want to hit M mode again, and you get this tracing right here. The x-axis is time in second increments, here and here and here, and the y-axis is the depth. This shows the IVC diameter change over time. The widest diameter is the maximal diameter here, and the narrowest diameter is the minimal diameter here. So you can do your equation where you subtract maximal from minimal, and you divide by minimal, and if it's greater than 18%, then according to the distensibility index, you have someone who can tolerate fluids. So once again, with the simplified approach, you want to check for pulmonary edema. If there is presence of pulmonary edema, go straight to vasopressors and don't use fluid. If there is no presence of pulmonary edema, then we'll want to look at the systolic function curve. And we'll also look at the IVC diameter change. And if there is normal or hyperdynamic systolic function, and also more than 50% respiratory variability associated diameter change with the IVC, or in those who are mechanically ventilated 18%, then we can give fluids. And once we give about 1 or 2 liters, we want to recheck this again. Now, if there is poor LV function and the IVC has less than 50% or 18% respiratory variability diameter change, then you want to go straight to vasopressors.
Hey, I was wondering if you could teach me some advanced measurements in fluid responsiveness, specifically things like LVOT, carotid flow times. That would be great.
I'm glad you finally asked, Ricky. So now going back to the trial and measurement concept. For trial, we're looking at the passive leg raise or small fluid balance, or respiratory variability, and the intrathoracic pressure change. And then for measurement, we're still sticking with cardiac ultrasound, but now we're actually looking at more advanced measures. First, you have the left ventricular outflow tract delta velocity time integral, or maximal velocity, or delta VTI or Vmax. You have the delta carotid blood flow, delta carotid flow time, and any Doppler-derived measurement that is dynamic. They all rely on the same basic principles, which are here. So we're using the trial and measure concept to predict fluid responsiveness. We don't actually have to measure the stroke volume or cardiac output, and here's why. Remember that cardiac output is equal to heart rate times stroke volume. However, heart rate is something that we can't really adjust and is not as important for predicting fluid responsiveness. So it's more like a constant or error term. So we drop that heart rate, we have stroke volume, which is equal to the velocity time integral multiplied by the cross-sectional area of flow. This cross-sectional area is calculated by multiplying the square of the radius of the lumen by pi. Fortunately, this doesn't change very much, so we can actually take this out of the equation. Now we are left with the VTI, which is the sum of all velocities in one systolic cycle. It is the area under the peak, here, here, and here. Why are we seeing different peaks, and what does that mean? Well, if we hold the cross-sectional area and heart rate to be equal, we are actually seeing changes in stroke volume or cardiac output. And remember that this change is due to the change in intrathoracic pressure in a respiratory cycle, in a passive leg raise, or in a small fluid challenge. And when this change, or delta VTI or delta Vmax, is greater than 10 to 20%, these patients are fluid responsive. So in effect, the delta VTI or Vmax, which is the maximal velocity of the peak, approximates the change in stroke volume or cardiac output. And we can do this as the blood exits the heart in the LVOT. We can do this in the carotid artery, in the brachial artery, or the femoral artery. For the LVOT, we'll find our apical 4-chamber view, slightly flatten our tilt angle to get a 5-chamber view, and then hit the Doppler button here, and we'll get this gate drop. Now we want to use our trackpad to center this gate so that it's just proximal to the aortic valve right here. This is the LVOT, and once we're satisfied with the positioning, we'll hit the Doppler again, and we'll get this spectral tracing of the actual velocities coming out. Notice that they're actually negatively deflected because the flow is actually going away from the probe. And you also want to optimize the image by adjusting the sweep speed so that you can actually capture one respiratory cycle. You'll want to increase the scale right here. Notice that this is 100 centimeters per second so that the waveforms are large and you can appreciate any differences. You also want to adjust the baseline by moving this up and down, as well as the gain or the signal intensity of the peaks themselves with these buttons just below the screen, as well as the knobs to the side right here. Once we're satisfied, we'll hit the freeze button, and that will stop the collection, and we can use the gain button to go back and forth. What you want to do is to find the tallest and the smallest peaks, and then you'll want to do measurements of those. In order to get a VTI, you want to hit the calculation button, and on the left side of the screen you'll get options to find the aortic valve or AV, and then you'll scroll down to LVOT VTI, and you'll be able to use the trackpad to trace this peak right here. You can also use the auto tracing mechanism, which is a little bit easier to do. And what you'll notice once you hit save is you'll get this tracing value, 19.2 centimeters. You'll get the maximal velocity or Vmax as well. And you want to repeat this measurement with the smallest peak, which is probably here. And again, you can do your calculation of whether the delta VTI or Vmax exceed 10 to 20%. However, if you just want to focus on Vmax while using the calculation package, you can hit the caliber button, and then what will happen is that you'll be able to basically measure from the baseline to the peak right here. And again, you want to identify the large and small peak, and you'll just get the Vmax measurement. Remember again that a delta Vmax or VTI that is greater than 10 to 15% will predict fluid responsiveness. Now you can perform similar measurements using the carotid, brachial, or femoral artery. Instead of using the phase array or cardiac probe, we'll use the linear probe, and we'll make sure that we're on vascular exam presets, which you could see right here. First, obtain a short axis view of the vessel. Here is the carotid, and we're slowly going to rotate the probe clockwise until we get a long axis view of the carotid artery. Next, hit the Doppler button again, and then you'll get this gate drop. Use the trackpad to center the gate. Typically, you want to move the gate towards the edges here or here, and also adjust the correction angle so that it's parallel with blood flow. This will increase accuracy of your Doppler measurements, which we'll discuss a bit later. Hit the Doppler button again, you'll get this tracing. You'll want to adjust the sweep speed as before with these buttons, as well as the gain with the knobs on the left. And once you optimize your signal, then hit freeze. You can scroll back and forth again using the gain buttons, and you want to identify the largest and the smallest peaks. Here there's really no difference. From one peak to the next peak right here, this is one cardiac cycle. So this is the systolic peak. There's a little notch right here. This is a dicrotic notch, and this corresponds to when the aortic valve closes, and there's a temporary loss of forward flow and sometimes early flow reversal in diastole. So this dicrotic notch symbolizes the end of systole and the beginning of diastole. Similar to the LVOT, delta VTI, Vmax function, you can hit the calculation package, and then you'll get this volume flow option where you can sample the diameter of the blood vessel so that you can get your cross-sectional area. And then you can sample the tap, which is a time average peak. This is similar to the velocity time integral in that it's the sum of all velocities that flow through that blood vessel. The difference is that the tap represents all the velocities over the entire cycle, whereas the VTI represents velocities only during systole. Blood flow calculation uses the sum of velocities multiplied by the cross-sectional area. Just note that the tap represents blood flow through the entire cardiac cycle, whereas stroke volume is only for systole. Now you can also use the caliper button here to look at just the peak systolic velocity, which is really the same thing as the Vmax. And again, you want to find the tallest peak and the smallest peak and measure the difference of the delta. And a delta greater than about 10 to 20% will also predict fluid responsiveness. Arterial Doppler delta Vmax, or blood flow, has gained traction because it is easier to perform than LVOT measurements. Think of it as doing a femoral line or an IJ, but instead you're looking at the carotid or the femoral artery, and you can see how easier it is than actually getting an apical 5 chamber. However, there's one major limitation to arterial Doppler, and this has to do with the accuracy of velocity measurement and its relationship to the difference between the inclination angle, or the direction of the sound beam, and the direction of the actual blood flow. So for instance, remember that Doppler depends on a frequency shift. So the sound beam will hit an RBC here and then bounces back. And it's this frequency shift due to the movement of the RBC that gives us our velocity measurement. However, the RBC is actually moving in this direction. So that shift is dependent on this angle theta right here. For blood flow that is parallel to the sound beam, this angle is 0 or 180 degrees. And the cosine theta function equals 1. So there is no resultant adjustment to the velocities in the Doppler shift that's measured. When blood flow is perpendicular to the sound beam, there is no Doppler shift, regardless of how fast the blood is actually flowing. Cosine theta at 90 degrees or 270 degrees will be 0. This is why you want to sample at the edges, because you can reduce this angle theta and therefore get a better estimate of flow. In general, any angle greater than 20 or 30 degrees will lead to increases in error in estimation. This can be problematic because most of the vessels will run in a perpendicular fashion compared to the probe. In addition to sampling at the edges, you can also angle the probe to image the vessel in a less perpendicular position. However, in daily practice, it is often difficult to reduce this inclination angle below 20 degrees. Is there another measurement for fluid responsiveness that is independent of inclination angle? Flow time is one such. This is independent of inclination angle because we're actually just looking at the ratio of the systolic time to the cardiac cycle time. So again, look at this dichroic notch. This symbolizes the duration of systole, and this from gate to gate symbolizes duration of the entire cardiac cycle. You can take this measurement by hitting the caliper button and just basically moving the cursor from horizontally versus vertically, and you'll get the millisecond value. And once you get the measurement for the systolic time and the cardiac cycle time, you divide the systolic time by the square root of the cycle time, and you get this flow time measurement. This is usually done for carotid, but you can do this for brachial as well as femoral artery. There is no widely accepted cutoff for flow time because it is so relatively new. However, if the flow time is 0.3 at baseline and then increases to 0.5 after a passive leg raise or fluid challenge, you can assume that the patient will be fluid responsive. Speaking of which,
I've heard about the passive leg raise. How do you do it?
Great question, Kit. So the passive leg raise first is an autobolus. It delivers about 300 to 500 milliliters of blood from the lower extremities to the thorax, and it is completely reversible. So you start the patient out recumbent about 45 degrees. Note that the blood is actually pulling away from the thorax to the lower extremities. And we'll do our initial measurements, our baseline measurements here with the patient in this position. Then we'll place the patient so that his or her thorax is parallel with the ground, and we'll raise his or her feet about 30 to 45 degrees. And what that achieves is an auto bolus from the lower extremities, about 300-500 cc's, to the thorax. Next, you want to perform your post-passive leg raise measure, and you want to figure out what the change is. And it's this delta value that is very, very predictive of fluid responsiveness. The passive leg raise is the closest thing to a slam dunk in terms of a fluid responsiveness trial in the literature. How do you do a passive leg raise? Well, the first involves just your usual gurney. So you want to raise the bed up from the initial pre-passive leg raise position, and then put the patient in Trendelenburg so that the thorax, you can lower the bed just a little bit too, but you want the thorax parallel to the ground, and then the lower extremities in a 30 to 45 degree position. This is method number 2 for the passive leg raise. You can have an assistant lift the patient's legs, but often this can be tiring and somewhat unwieldy, as George demonstrates. Method number 3 involves a wedge pillow.
What's this I hear about the Sepsis 3.0, and how is it different from the Sepsis CMS Bundle?
Great question, Alex. Well, first, this whole SIRS sepsis definition lacks precision. It's not specific, as in the case of patients that have viral syndrome, those that are tachycardic due to pain, or those who have elevated lactates from beta agonists. It's not sensitive either. We all have had altered septic elderly patients who are afebrile or not tachycardic because they're on a beta blocker. The current sepsis definition also doesn't make a clear distinction between compensatory and helpful mechanisms like fever and tachycardia in sepsis, and maladaptive processes that led to end organ dysfunction. So this is where the Sepsis 3 definition comes in. This international group of sepsis specialists looked at different risk stratification models for sepsis and patient outcomes in a large retrospective study which involved over 150 institutions and close to 150,000 patients. What they recommended from this analysis was that you don't need to have the SIRS criteria anymore, you don't need to have sepsis, you really just need to start out with severe sepsis or signs of end organ dysfunction. What they found out was that in ICU patients, the SOFA score, or sequential organ failure assessment score, which incorporates 6 organ systems here and assigns a score of 0 to 4 for each organ system according to increasing dysfunction. If that SOFA score is greater than 2, that will triple the mortality. Now in the ED patient or in other patients where you don't necessarily have the data to calculate a SOFA score, you can actually use a quick SOFA or QSOFA, and if you meet more than 2 out of the 3 criteria, that is also predictive of this new definition of sepsis. Patients need to have hypotension, altered mental status, or tachypnea with a respiratory rate greater than 22. So if you have 2 out of 3 of these criteria, then you should really suspect sepsis. So how do we put these concepts together? The Sepsis 3 definition eliminates the SIRS as well as sepsis definitions. And what both Sepsis 3.0 and the CMS Sepsis Bundle are concerned about is whether there's presence of end organ dysfunction. In the ED or ICU setting, you can use either the quick SOFA or the SOFA. And if you're talking about the CMS bundle, you can look for severe sepsis. And this is where the sepsis bundle is triggered, which means that we're responsible for these core measures. A key point is that the Sepsis 3 definition has not been endorsed as of April 2016 by CMS or any of the major U.S. specialty groups like ACEP or ACCP.
So I have a patient with pyelonephritis who's presenting with an elevated INR of 3.0, but she's known to be on Coumadin. Is this someone I should activate the sepsis protocol on?
Great question, Samshir. So how can one opt out of the sepsis bundle? First, you can document that there's no evidence of end organ dysfunction. If the abnormalities are expected or chronic, as in the case of liver disease and the bilirubin or coagulation, as well as someone who is on anticoagulation. If the renal function is diminished due to CKD, if you document this as baseline, then you can opt out of the sepsis bundle. If patients are in comfort care, then they can opt out as well. Or if they're transferred from an outside acute care facility, they can opt out. Last, if they actually present already on antibiotics, they can be opted out of the sepsis bundle. So in summary, for the management of sepsis, you want to make the diagnosis of end organ dysfunction via the traditional severe sepsis criteria, or you can use the SOFA in the ICU or the quick SOFA in the ED. Once you have that, you trigger the CMS bundle, which gives you 3 hours to collect the cultures, give antibiotics, collect the lactate, and IV bolus if indicated. And if they still have refractory hypotension, within 6 hours you want to redraw the lactate and start them on the vasopressor or give them more fluids depending on your focus exam. Remember that for any exam, we have a trial method like the fluid challenge, passive leg raise, or respiratory variability. And then we have the measurement itself, which can be either the focus exam for tissue perfusion, invasively derived measures like CVP or CVO2, or bedside ultrasound. There are 2 ultrasound protocols. The first is the Simplified method. Check first for pulmonary edema with B lines, and if they're present, avoid fluids and go straight to inotropic or vasopressor support. If there is no pulmonary edema, check systolic function as well as IVC variability. If there is poor systolic function and little IVC respiratory variability, go to depressors. If the systolic function is normal and the IVC variability is greater than 50% in a spontaneously breathing patient or 18% in the mechanically ventilated patient, you can give fluids, and you want to repeat this assessment after every 1 or 2 liters of fluid. The advanced ultrasound protocol incorporates Doppler measurements to look at changes in velocity pre and post trial, and the trial can be either a passive leg raise, a small 100 cc fluid bolus, or respiratory variability. And you can measure at the LVOT, the arterial Vmax or blood flow, the flow time change pre and post passive leg raise, and if the delta measurement exceeds 10 to 15%, then these patients are fluid responsive and can benefit from fluid bolus. Okay, now it's time for you guys to do some active learning. Let's go through a couple of cases to see how well you test. First, we have a 75-year-old woman who presents from a nursing home for lower abdominal pain. She is febrile with a blood pressure of 120/80, her heart rate is 80, and her respiratory rate is 23. She has altered mental status, but no focal neurological deficits. Does she potentially trigger the sepsis bundle? A. No, she's being transferred from a SNF. B. No, she's not hypotensive. C. Yes, because she has signs of end organ dysfunction. Or D. Yes, because she probably has a UTI. The correct answer is actually C. A is incorrect because a SNF is not an acute care facility, and she does not opt out of the sepsis bundle, if that's what some of you guys were thinking. B is also incorrect because the sepsis bundle is triggered when patients have end organ dysfunction and not septic shock, and this is why C is correct. D is probably true too, but there are a lot of patients with pyelonephritis who have no end organ dysfunction that do not trigger the sepsis bundle. This is why the quick SOFA is so helpful in the ED. If patients have 2 out of the 3 of the criteria, hypotension, altered mental status, or tachypnea greater than 22, then it's a predictor of end organ dysfunction and sepsis. So her urinalysis is positive, her lactate level is 3.0, you initiate blood cultures, broad spectrum antibiotics, and now she is hypotensive with a blood pressure of 90/60. You give her 30 cc per kg normal saline bolus, and 30 minutes later you perform a simplified ultrasound protocol. So her repeat blood pressure is 88/50. What is the next best step in management? Do you give another fluid bolus? Do you perform an abdominal aortic ultrasound? Do you perform a stat head CT? Or do you initiate a norepinephrine drip? The correct answer is a repeat fluid bolus, and the reason is because there were no B lines or no evidence of pulmonary edema. The systolic function was still normal, and she still had normal respiratory variability of her IVC. Abdominal ultrasound may be a possibility if you didn't know that the patient was already septic and you're rolling out a AAA, but this isn't the case. Same thing with a stat head CT. We know that she's altered and that she has a normal neurological exam. And because she's infected, that makes a stroke a less likely cause of her altered mental status. You should initiate a norepinephrine drip when patients are not fluid responsive, and I do realize that there is some controversy to this. Her repeat blood pressure is 80/50. Her repeat ultrasound assessment is as follows. Is there anything different from her prior ultrasound findings? So she continues to be hypotensive. What is the next best step? Do you repeat the bolus a third time? Do you perform that abdominal aortic ultrasound, that head CT? No, the answer is that you initiate the norepinephrine drip. And it's because she now has B lines, and more than that, if you actually go back to the systolic function, it's actually a little bit depressed, which we can see in about 50% of our septic patients. So now she's no longer fluid responsive, so that's why we initiate the norepinephrine drip. Now, before I go on to case 2, I'd like just to point out that clinical judgment always trumps any protocol or anything to do with question taking. I realize that, but for the purposes of active learning and making sure that you're understanding the content, we have these questions. So for case 2, we have a 68-year-old male who presents with pneumonia and septic shock. Because he has COPD, his lungs are really hyperinflated and it makes it difficult for you to obtain echocardiographic views. And he's also pretty obese, so the IVC is hard to image as well. So what is your next best step in management? Do you rule out a pneumothorax with ultrasound? Do you get a stat echo from the cardiologist? Do you perform a carotid Doppler with the passive leg raise as your trial? Or do you place a central venous catheter? The answer is, because we're talking about fluid responsiveness, is to perform the carotid Doppler with the passive leg raise as the trial. So this is your carotid Doppler tracing. You have your baseline peak prior to your passive leg raise on the left-hand side, and on the right-hand side is your post-passive leg raise tracing of your carotid. According to this, do you give 30 cc's per kg of normal saline bolus? Do you initiate norepinephrine? Do you take the central line out of the carotid artery, or do you perform a chest thoracostomy? Obviously, C and D are throwaway answers. So this is a matter of, do you think based on the spectral Doppler that the patient is fluid responsive or requires vasopressive support? The patient is fluid responsive, and the reason is because if you just trace out the maximal velocity, or Vmax, you'll see that the delta Vmax is going to be greater than 10 to 20%. So you give 30 cc's per kg of bolus, and he still remains hypotensive. Now you perform another passive leg raise and obtain this carotid Doppler tracing. So on the left again is the baseline, and on the right is post-passive leg raise. In this case, do you give the 30 cc's per kg repeat bolus, or do you initiate norepinephrine? Because the Vmax does not change at all, or very little, this is where we know that the patients are not going to be fluid responsive, and so we'll initiate our vasopressive support. I hope you found those questions helpful. These are selected references from my talk. Many thanks to the contributors to this video, as well as the excellent work of my colleagues and those in the ultrasound community to improve the management of our patients. Hey, listen, I hope you had a good time watching this webinar and that you're able to take at least 1 or 2 pointers away for your next shift. If you have any questions or comments, I'd love to hear them. Please send me an email or a tweet. Thanks again. Bye.